The evidence we have for improving quality and safety in healthcare, first of all, there's a range of factors that contribute to the way care is provided and whether that's good care or not so good care. So the first thing that needs to be thought about is to align all those different factors to be pulling in the same direction. Now, whether they be how we fund hospitals, how we pay doctors, whether they be accreditation schemes or public reporting or local collection and measurement of data, they all need to sit within a nice, neat framework in order to really generate those force multiplying effects that we see where successful health services are able to deliver really high quality care. The second is you need to really work with your key stakeholders, and they of course are the clinicians and the clinical teams who deliver the care, and also of course the consumers and the patients. So the interests of those two groups, while they might slightly differ, need to be combined into that framework that's going to drive your high quality care. And the third, as I said during the Q&A session, we must collect, analyse, interpret and feedback good quality data back to people who are providing the care, and to give them an idea where they are in terms of their outcomes, their patient outcomes, and how they compare with their peers. So harness those sort of competitive instincts that most people have, particularly clinicians, and also harness the fact that at the end of the day, everybody wants to have the best possible outcome for their patients, and that's really what drives people on a day-to-day basis. So they would be my three key things according to the evidence. So certainly something that should be avoided is an isolated pay for performance initiative that doesn't sit within a broader quality improvement framework. So the repeated themes in the failure of these schemes to work is where it's a thought bubble occurs, someone has an idea, okay, we'll incentivize something, a certain process or a certain outcome, and apply that without thinking about how that's going to affect the broader ecology of that hospital or that health service, because you pull a lever here and something else happens there. So there's always unintended consequences. So that's why putting everything into a nice cohesive framework is the only way to go. So I think that the principal danger is to focus on one thing through one lever, and that's a recipe for failure. So it should be more of a holistic approach that harnesses all the different factors that contribute to good, safe, quality care, whether they be financial or non-financial, whether they be extrinsic or intrinsic type of motivational levers. So I think working on something in isolation with using only one lever is probably the key danger, and that would be something that we would recommend strongly for health services and providers to avoid.